Is Dr. Atheeshwar Das here? Dr. Atheeshwar.
Yeah. So he is going to talk his experience within a TriPhobic trifocal IOL.
Podium 1. Very good morning. I'm here to share with you my experience with the TriPhobic trifocal, the new kit on the block. We did a comparative analysis of diffractive trifocals with extended range of vision in our center. It was a one-year study. So this was the aim of the study, to compare the visual quality and outcomes. We included around 55 patients with 110 eyes. All were operated in a single center by a single surgeon. So these were the lenses which we compared. Physiol trifocal, true trifocal diffractive IOL, the Zeiss 80 Lisa trifocal, and the Acryvision or the TriPhobic trifocal of Care Group, the EDOF lens of Symphony. And we did also include the toric trifocal in those patients who had high cylinder, more than one diopter pre-existing. So all of them underwent uneventful bilateral cataract surgery between August 2021 to 23 year. And we used optical biometry with LensStar. We did a complete preoperative exhaustive evaluation, which I will just highlight due to paucity of time. We did do a complete dry eye evaluation. Those who had moderate to severe dry eye were excluded, and those with high angle kappa measurements in the topographer were also excluded beyond 6 degrees. Anyone with prior refractive surgery were excluded, and also people who had macular pathology or retinal laser were also excluded. So these are the lenses we compared. So the broad base differentiation between the lens here, you can see I like to highlight about TriPhobic, which had around 92% light transmission, where 50% was distance, around 20% for intermediate, around 30% for near. And it is pupil independent. Same thing with like PanOptics, which has enlightened technology. And these were cast-mounted lenses, the TriPhobic, so that amount of glare and halos were considerably less. So there are different technology or the commercially available diffractive IOLs. You have the trifocal diffractive apodized lens, which is a Physiol. Then you have that trifocal diffractive non-apodized, which is PanOptics with the enlightened technology. The TriPhobic has an increased angulation and decreasing height from the center to the periphery in their trifocality. So this gives them better amount of focus and also reduces glare and halos. Since they are cast molded lenses, they have less imperfections, and the defocus curve is also very gratifying. I'll share with you our details, our study. This is the energy scan which they have given to me from the company about the MTF values. So you can see the MTF values is good in near, intermediate, and distance as well. So just a video of this patient who underwent trifocal toric implant. He had a pre-existing diopter of 2.5 cylinder. I always aim for a 5 mm rexis, circular and centered. We do a pre-operative marking, and these patients are always done under topical anesthesia. We ask them to focus on the lights, coaxial lights, and try to center it around the first Purkinje images. I'll just move out for the paucity of time. A routine phacoemulsification, and this was the lens which was implanted. 11 degree was the axis. So you can see it comfortably goes through a 2.2 mm corneal tunnel. Once implanted, we always ask the patient to foveate or fixate the coaxial light, then center the lens accordingly. This patient was centered at 11 degree axis, and post-operatively, he was 6.6 and 6 unaided. This is another similar patient. Due to paucity of time, I'll skip to the next video. These are the 4 different lenses we compared. Zeiss 80 Lisa Tri goes through a 1.8 incision. Smaller, the Physiol, however, required wound-assisted implantation because it was a much larger lens of 6.25 mm optic. The Synergy has a screw-type cartridge, so you can't do it with one hand. You need a bimanual implantation, the Synergy. The TriPhobic goes through a butterfly cartridge, which is smooth and easy to deliver. So another small note over angle kappa. We did analyze angle kappa preoperatively with the ocular topographer, and we found that angle kappa doesn't have a great impact in the postoperative visual outcome, unless there is an excessive amount of decentration. Angle kappa, the chord length is between the visual axis and pupillary axis. If the chord length is more than 0.5 or 0.6, we try to exclude them, but only when there is decentration. This is a small slide which I picked from Dr. Uday Devgan on his cataractcoach.com, where he says that the negative aspheric IOLs are more prone for comas if they are decentered mildly. Even a 0.5 mm decentration causes coma. However, the trifocals, I didn't encounter much amount of comas or aberrations postoperatively, because we always centered them, asking the patient to foveate the coaxial illumination, and we centered them on the first Purkinje images. So this is how we centered. This is the optical axis, and that's the pupil center, and we try to center them according to the pupil center. So in all, 22 males or 44 eyes and 33 females, 66 eyes included in the study. Distance visual acuity was recorded at LCD chart at 3 meters. We also used ETDS chart at 4 meters. Near and intermediate visual acuity is recorded with a column branded chart, and subjective position of glare and halo were recorded with the images shown. So this was the conversion we used, logMAR to Snellen equality. This was the distance visual acuity tested at 3 meters on an LCD charge and converted to logMAR. Here you can see all the 3 lenses performing extremely well at 1 week, 3 months and 6 months. They all were 6 by 7.5 or 6 parts unaided. So the ETDS chart at 4 meters, we found that initially the patient, because it was not illuminated chart, the ETDRS, so initially they were 6:12 or 6:9 the first week, and slowly they improved with binocular implantation to 6 by 6 end of 6 months and 1 year. This is the colon branded chart which we used for intermediate vision at 63 centimeters. So at 63 and 40 centimeters, again you can see the trifocal lenses were doing well, diffractive trifocal, triphobic doing well for near and intermediate. However, the symphony wasn't good for intermediate and near vision. However, we had to do a micro monovation of the fellow eye so that binocularly they are able to read N8 or N10. So this is the intermediate chart we use at 100 centimeters. And the intermediate chart, Colin Brander at 100 centimeter, again showed extremely good outcomes with Physiol. It's the diffractive trifocal. Similarly with 80 Lisa Tri, and Triphobic also matched up at the end of 3 months and 6 months. So these are the Bardell images which are given to us by the different companies. Again, I would take this with a pinch of salt because it varies predominantly. I wouldn't go by what is shown here. This is a description about how the focus is there on intermediate and near focus, amount of glare and halos. So this is intermediate vision with the trifocal. As you can see here, 80 Lisa Tri gives the best trifocal clarity with intermediate vision. So post-operatively, we assessed for PCO with retroillumination at 6 months and 1 year, and we found that the hydrophilic lens, the 80 Lisa Tri, had more incidence of PCO, and we had to go for a selective yak capsulotomy much earlier. So to summarize, accurate preoperative biometry is very essential when you're going with these trifocal implants. Look at angle kappa and the chord length measurements if you have an optical ocular topographer. Go with universal Barrett formula, aim for a central rhexis. The right IOL, I would prefer in a myope with presbyopia, go with a trifocal with hybrid vision, that is a fusion IOL or a EDOF IOL and a trifocal in one eye. Hyperope with presbyopia do very well with trifocal IOLs implanted bilaterally. And very important, complete removal of OVD from behind the IOL to avoid capsular back distension syndrome in these patients, because we would definitely opt for the second fellow eye surgery within 2 to 3 days after surgery. And if there's any refractive surprise, we wouldn't try to go with this fellow eye surgery immediately. To conclude, trifocal IOL provides a good range of vision when implanted binocularly. The subjective photic phenomenon is more with Physiol compared to AT-LISA trifocal, compared to TriPhobic, and Symphony had the less photic phenomenon. PCO rates, posterior capsular opacification, was much higher with AT-LISA trifocal, 4 out of 22 eyes, due to the hydrophilic nature of the lens, and we plan to do an early YAG capsulectomy, and we did for 3 months and 1 month also. Near and intermediate vision were good with AT-LISA trifocal and TriPhobic. Symphony implants, however, didn't offer good unaided near vision, and micro monovision was planned for the fellow eye. Thank you for your kind attention.
I think very well captured, Dr. Sridhar. Just a couple of questions. I believe that a surgeon's faith in a lens is, would he do or use that lens for a clear lens extraction in a patient who's probably seeing well for distance and he's looking for near vision. That's my hallmark. What is the lens I would put for a person who comes to me for just a simple refractive correction and he's 50, 54, 55, 56? So in your opinion, would you be putting a trifocal lens?
It's always been it's the holy grail in ophthalmology. We are not able to get the ideal lens which suits everyone. It again depends on his refractive error. Like I said, for a hyperope and who's a presbyope, who's extremely dependent on glasses. For example, he's got plus 2.5 for distance and 2.5 for near. I would definitely aim for a trifocal in him. However, a myope who's like -3 and he's got very good near vision, I would again not push him for a trifocal immediately. I would try to do a fusion or a hybrid lens, one eye with a trifocal and other eye with a fusion lens like Lucidis, so that the amount of glare and halo is reduced for him and he's got a blended vision. Complete range of near and intermediate vision.
Yeah, wonderful. I think that's what the carry home message I wanted for the audience, that whenever you're treating the moderate myopias for clear lens extraction, don't be overambitious. That's exactly what you said. And hyperopes are ideal candidates for these kind of lenses, but then again, the factor of angle kappa comes in. So you need to watch out there. One question to you, if a patient is having a dry eye, and you plan doing this surgery, what would you do? You treat the dry eye. Do you do a dry eye mapping again? When do you take the patient up again for that?
So routinely we do a pre-operative dry eye evaluation, myogram. So mild to moderate cases, you can go ahead with implantation of these premium trifocal lenses. However, if they have moderate to severe, I wouldn't counsel them for these trifocal lenses, because post-operatively they are going to come repeatedly back to you, even with punctal plugs on table. I have tried on a couple of patients who had dry eye, put a punctal plug with trifocal implant, but the dry eye didn't really resolve, and they do have intolerable glare and halos post-operatively.
I think, again, Dr. Rishi was talking about the post-operative dry eye, and what I'm trying to highlight here is the importance of a pre-operative dry eye, and Pooja here is an expert in that. It's a must thing when you're trying to do these high-end lenses. I call them the light-bending IOLs. You know, they are the NTLs or the new technology lenses. You do not take them up without doing a dry eye mapping. And my last question is, since we have the armory of OCT, so many patients you see ERM, at what level will you decide you will be doing a trifocal or not?
So ERM is never a absolute contraindication for these trifocal or the ERV lenses. Again, it depends on the foveal contour. We grade the ERM type 1, type 2, and type 3. Type 2 and type 3 you have to be wary. Type 1, which is the early ERM, which doesn't have any anteroposterior traction, doesn't cause any tangential traction, you can go ahead. With the enhanced depth OCT nowadays, it's becoming much easier to quantify this type of ERM. So I would definitely say, please do get an OCT, SD OCT, or an enhanced depth OCT imaging in all these patients who are going for the trifocal implant.
I think that sums up my question. And I would just like to declare that probably the era of bifocal is gone. We either have the EDOFs or enhanced monofocals or the trifocals. So,
thank you.